Dear colleagues, our subject, operative surgery and topographic anatomy, is a twofold discipline. This consists of the unchanging part, which is topographic anatomy, more or less, the academic part, and dynamically developing part of operative surgery. The first part, topographic anatomy or regional anatomy, involves the study of the correlation of organs in orientation known as syntopy, the relationship of organs with bones of the skeleton known as skeletopy, and finally, the projections of the organs on the body surface into areas or regions of the human body from the surface down, the same way as the surgeon's scalpel would move. This is known as holotopy. The second part, which is operative surgery, involves the study of the most general and classical patterns of treatment of various diseases surgically, and the mastering of the basic practical skills needed of every doctor. Surgical intervention can be classified in different ways. By choosing classification based on time, surgical intervention may be emergency, urgent and routine, or planned. Depending on surgical specialty also, they can be divided into general surgery, vascular surgery, cardiovascular surgery, neurosurgery, ophthalmic surgery, gynecological surgery, among others. According to the number of stages, surgical intervention can be single and multi-segmented. This particularly applies to constructive operations. Operational intervention can be categorized as radical surgery, surgery that is usually extensive and complex and intended to correct a severe health threat, and palliative, when we unfortunately seek to alleviate but not cure the patient's condition, as in most cases of oncological interventions. One of the highlights in operative surgery is the patient position on the operating table. This depends on many factors such as the number of members on the operating team, localization of access, the choice of access, choice of the direction of the cut, and choice of method of surgical treatment or other surgical diseases. Positioning of patient on the operating table also depends on the topography of the organ. For example, for a more optimal access, during operations on the pelvic organs, gynecological and urological surgery, the Trendelenburg position with the raised pelvic end of table is often used because the organs naturally fall under the force of its gravity. At the end of our department is a board displaying the minimum of surgical instruments and the names of which must be known by each student. Surgical instruments can be divided into two broad groups: general-purpose instruments, which are used in all surgical interventions, or most operations, and special-purpose instruments, which are used in certain operations or at certain stages of special surgery. Based on their functional designation, surgical instruments can also be categorized into instruments for the separation of tissues, instruments for joining tissue, and instruments for the retention of tissue or to create exposure. For separation of the tissues, different kinds of scalpels, knives, pliers, chisels, saws can be used to create the excision. For joining of tissues, needles, needle holders, and clamps are used. For retention of tissue or to creation of exposure, retractors are used. Before me is a set of general surgical instruments. Here there are scalpels, scissors, needle holders, clamps, probes and the retractors. Before we demonstrate the use of these instruments, we need to first talk about the effect of using different cutting instruments. Soft tissues can be cut with both scalpels and scissors. However, different results are obtained due to their different mechanisms of dissection. If we use a scalpel to cut tissue, the mechanism of separation of tissue would be such that the sharp edge of the blade cuts through the tissue, resulting in uniformly separated layers. But with tissue dissection using scissors, the jaws do not only dissect the tissue, but also knead them together, making it impossible to have uniformly separated layers. We therefore use scissors to separate the tissues only when the object is thin or in a vascular lamellar structure, such as fasciae, peritoneum, pericardium, dura mater, and so on. The scalpel has a handle and a blade. The opposite side of the cutting edge is called the butt. The scalpel can be held in four ways: the pencil grip, the fingertip/violin grip, the palm/table knife grip, and amputation grip. Although each grip can be used to incise tissue, each has its advantages and limitations. Pencil grip. In the pencil grip, the scalpel is grasped close to the blade between the tips of the thumb and index finger, with the remaining handle resting on the web of the thumb, much like grasping a pencil. In this grip, the motion comes predominantly from the thumb and index finger, allowing for precise cutting of tissue. To increase the accuracy of the fine cutting, you can also steady your hand by resting it on the patient as you cut. The pencil grip can also be backhanded by reversing the direction of the blade without changing the upper arm position. Advantages. Grasping the scalpel handle like a pencil allows short, fine movements, using the muscles of the hand, with less contribution from muscles of the forearm. The pencil grip is therefore most useful for making small, precise incisions. Limitations. In the pencil grip, the blade edge is held at a 30 to 40 degree angle to the tissue. In comparison to the other scalpel grips, this greater angle diminishes the cutting edge contact, limiting both depth and direction control. Thus, the pencil grip is not ideal for creating long, straight skin incisions. Fingertip/violin grip. In the fingertip grip, the scalpel is held between the thumb and middle finger, while the index finger is placed on the spine of the scalpel blade to apply downward pressure, much like grasping a butter knife. This grip is used primarily for making long skin incisions, using arm motion, rather than using the finger motion associated with the pencil grip. Advantages. The chief advantages of the fingertip grip are that it provides good depth and direction control. Because this grip maximizes the length of blade that comes into contact with the tissue, any changes in blade pressure are distributed over a greater length. This delivers less pressure to each increment of tissue and allows for greater security of depth control. Additionally, the greater the length of tissue in contact with the scalpel, the more the walls of the incision resist minute or sudden changes in direction, allowing for smoother, straighter incisions. The combined advantages of both depth and direction control make the fingertip grip well suited to creating long incisions. Limitations. The fingertip grip does not allow for precise blade cuts, so it is not used when delicate, precise scalpel cuts are required, such as in ophthalmic and vascular procedures. Palm/knife grip. In the palm grip, the fingers are wrapped around the scalpel handle and the thumb anchors the handle. Force is applied to the handle with forearm pressure and the wrist is held straight. Cutting begins by inserting the scalpel at 90 degrees angle, turning it to 45 degrees angle to continue along pattern of choice and returning to 90 degrees angle at the end of the cutting to remove the scalpel. Advantages. The palm grip is the strongest, most secure way to grasp the scalpel handle, but it is rarely indicated for most surgery applications. Its main surgical use is when great pressure is needed to cut through very dense tissue. The most common use for the palm grip is to cut open cadavers during a necropsy examination. Limitations. In the palm grip, the grasp is held well away from the cutting blade edge and forearm pressure is used to exert force, resulting in little control over blade pressure. This lack of pressure control means that the palm grip should not be used for surgeries that require accuracy and control. The inaccuracy results from participation of large joints, large shoulder muscles and shoulder girdle in the movements. Palm/knife grip. In this type, the scalpel is held with the fingers and thumb wrapped around the handle of the scalpel. The cutting edge of the scalpel faces away from the surgeon. Advantages. The advantage is that it allows for swift movement of the amputation knife around the structure to be amputated and gives a deep cut. Limitation. In this grip the cutting is not very accurate. Rules of surgical incision. When performing surgical incisions, certain rules need to be considered. These rules aim to prevent complications and to optimize the performance of the methods of separation of tissues. Incisions are performed in layers, with each layer being separated and cut with a separate motion, except for skin and subcutaneous tissue, where we try to cut with fewer movements. This rule applies to the dissection of the muscles in the transverse direction. However, if the operation requires dissection of the muscle in a cross-sectional direction, it is better to do fewer movements, as a lot of movements may result in a reduction of dissected muscle fibers and cause the stepped configuration of the wound. Thus, after connection of the wound, which is such a configuration between its surfaces, there will be seepage of tissue fluid, blood, lymph, which can serve as breeding ground for microbial growth and also a favorable conditions for the suppuration of postoperative wounds. Again, if suppuration occurs, the rate of healing of wounds would slow down. Muscles are dissected with one movement of the scalpel and the incisions should run parallel to the course of major vessels and nerves. Compliance with this rule ensures the prevention of damage to major blood vessels and nerves. To ensure the most optimal cosmetic effect when performing surgical incisions, it is necessary to consider the course of the line of pull of the skin. In the dermis, depending on a particular area, the collagen bundles of the fibers may move in one direction. If the cut is made perpendicular to the direction of these beams or lines of Langer, the scar when restoring the skin will be rougher. Therefore, for a better cosmetic effect and a more optimal way of making the scar less noticeable, we try to orient the cutting line parallel to the course of Langer's lines or the lines of tension of the skin. Cuts are performed from left to right and towards the surgeon. However, when a fluted probe is used or the dissection of tissue under the guidance of a probe, the cut is made in direction away from the surgeon. The fluted probe is used to protect important anatomical structures in tissues, for example, major neurovascular bundles. Surgical incisions are performed taking into account the requirement that provides for the same size and depth of wound in its entirety. In order for the wound to get the same depth, we must change the position of the scalpel as we cut. The incision begins with positioning of the scalpel perpendicular to the surface of the human body, that is 90 degrees. After a puncture from this angle, we change the position to 45 degrees and produce a cut, after which we again change the position to 90 degrees before removing the scalpel. One of the most important rules for surgical incisions is the conduct of cutting from the most dangerous place to the least dangerous place. This is due to the fact that at the beginning of incisions visibility and attention to the areas of intervention is better than at the end of the incision. Incisions are less accurate at the end of manipulations than the beginning, also because the surgeon's hand closes the place where the cut finishes, thus reducing visibility. In addition, complications from bleeding and other nuances may distract the surgeon during incision, reducing the accuracy of the cut and increasing the risk of other complications, such as damage to important anatomical structures. So again we start incisions from the most dangerous places where the risk of damaging anatomical structures is maximal and complete it in the least dangerous place, where the risk is minimal. An example of implementation of this rule is during midline laparotomy. In upper midline laparotomy, we start the incision from the top, the xiphoid process, and lead down to the navel, thus preventing damage to structures in the area of the xiphoid process such as the left lobe of the liver, which is adjacent to the ventral wall. In lower midline laparotomy we start from the bottom and move up from the wound to the navel, as there is a risk of damage to the bladder.
Заводят между поверхностями, между тканями и путем раскрытия бранши производят раздвижение, разъединение тканей тупым способом. В отличие от рассечения тканей, диссекция является, с одной стороны,
In addition to the classical methods of separation of the tissues, methods of tissue separation exist which may require the use of a special tool, example, the dissector. The dissector is often used in the practice of vascular surgeons for the purpose of division and separation of the neurovascular bundles from the surrounding tissues. Apart from the dissector you can also use any tool that has jaws. Jaws slid between surfaces and tissues, and by opening of the jaws, separation of tissues occurs in a blunt way by the pushing of adjacent tissues away from each other. Unlike incision of tissue, dissection is on one side a more traumatic method, since it leads to tissue damage in the form of lacerations. On the other hand, dissection prevents damage to major blood vessels and nerves. They are also modern high-tech methods of separation of tissues, such as the use of electric saws, the use of electrocautery, laser instrumentation, the use of plasma scalpel, and the use of different devices that create high pressure in the area of impact. Types of knots. There are many different types of stitches used for the fixation of tissues. There are also different ways of making knots after suturing. Within our discipline, we study 3 ways of tying knots. These are simple knot, reef knot and the surgical knot.
Простой узел менее прочный, менее стабильный, но преимуществом его является то, что после фиксации его можно дотянуть. Напротив, хирургический узел – это узел.
Simple knots are less strong, less stable, but the advantage of it is that after fixing it you can undo. The surgical knot is the strongest, but after tightening, it cannot be changed, and its configuration remains stable. That is, during the formation of this type of knot, the surgeon must consider the place, the degree of tension of the thread and tissue needed to make it stable.
То место, ту степень натяжения нитей и тканей, чтобы сформировать хирургический узел стабильным на том расстоянии, в том месте, которое является наиболее оптимальным. Хирургическую нить фиксируют третьим, четвертым и пятым пальцами.
In making knots, the surgical thread is held using the first and second fingers, while the third, fourth and fifth fingers remain
Для
fixed.
того, чтобы предотвратить перекрест нити при формировании узлов, нить правой и левой
To
руки
prevent the crossing of the filaments during the formation of knots, the thread in the right and left hands should be exchanged to preventing its decussation.
формирование простого узла начинают указательные
Simple
пальцы
knots.
левой руки.
In the formation of a simple knot, start with the index finger of the left hand, lock the thread and carry it from left to right. Then connecting the thumb and index fingers under the loop, hold it in a loop, move up, fixed the thread between the fingers and pull it down, thus forming the first loop. Second half knot form in the same way.
Таким образом формируя первую полупетлю. Второй полуузел формируют таким же образом. Морской узел
Reef knots.
формируют так
Forming the reef knot is also simple. The first half loop is executed in the same way as the simple knot. The second half loop of the reef knot is formed using the index finger of the left hand, from the inside, grasping the left strand, putting it on the top right hand thread, connecting the fingers, pulling them down. Then taking the bottom thread, tie them up.
кладут на нее сверху правую нить, соединяют пальцы, провязывают их вниз и снизу берут нить и провязывают ее вверх. Хирургический узел является
Surgical knots.
морского
Surgical or double knot is a modification of the reef knot, except that the first half knot is made double. And again this is followed by a simple knot.
И еще раз.
Let us repeat the demonstration again. Simple knots.
Морской узел,
Reef knots.
хирургический узел,
Surgical knots.